Hello everyone, myself Dr. Omkar Sangita Dilipra Sonone, and today I welcome you all back to the session of Sparks. Today's discussion is going to be about general pathology. So, in a retrograde fashion, let's discuss some important points about general pathology that you need to know. We have already discussed about cell injury and adaptations and also about neoplasia in a separate video. So, here we'll be discussing about the rest of the topics of general pathology. So, let's begin with the session. Now, over here, the first question that we have states that physiological hyperplasia and hypertrophy are simultaneously seen in. Simultaneously means at the same time. Okay, so in which organ we can see physiological hyperplasia as well as hypertrophy at the same time? As we all know, whenever a cell has an injurious stimuli or it undergoes stress, first of all it tries to adapt, right? It tries to adapt to the newer environment or to the stress. These are known as your cellular adaptations that we have already discussed. These are of four types, right? Either it can be atrophy or it can be a hypertrophy, it can be hyperplasia or it can be metaplasia, right? So these are cellular adaptations. Then if the injurious stimuli or still persists, okay, the noxious stimulus still persists, then it will undergo reversible cell injury. Okay, if on this also the injurious stimuli has not been withdrawn, then it further undergoes irreversible cell injury, which will finally land up the cell into cell death. Okay, and cell death we have studied, it is by different 5 mechanisms. That is, important ones are your necrosis and apoptosis, the rest are your necroptosis, pyroptosis and ferroptosis, right? So this is the basics of cell injury that you need to know for this question, right? So now there are 4 types of cellular adaptations we have discussed. First was atrophy, decrease in cell number as well as cell size. Second was hypertrophy, increase in cell size, right? So hypertrophy means increase in cell size, hyperplasia means increase in cell number, and metaplasia means change of one adult mature cell type into another adult mature cell type, right? So this is the basis. So यहाँ पे उन्होंने क्या पूछा है? They have asked which is an example of physiological hyperplasia along with hypertrophy. So let's see. Option A states skeletal muscle in athletes. As we all know, guys, skeletal muscle in athletes due to strenuous exercise, okay, usually in bodybuilders or usually in athletes, the skeletal muscles and they are under stress due to strenuous exercise, and due to this continuous stress they undergo cellular adaptation. But in this case, skeletal muscles are stable cells, okay, they cannot proliferate, therefore these skeletal muscles would undergo hypertrophy, right? And this is an example of physiological hypertrophy because it is occurring in normal circumstance, right? So this is an example of physiological hypertrophy, that is skeletal muscles in athletes. Second one, option B, left ventricular hypertrophy during cardiac failure. Right, after cardiac failure, what happens usually? The heart loses its function, or the muscles become unable to pump the blood. For that purpose, for compensation, what happens actually? The left ventricle, it gets hypertrophied. Okay, the cell size or the myocardium cell size usually increases, right? And this is known as your left ventricular hypertrophy, and this is an example of pathological hypertrophy. This is an example of pathological hypertrophy, right? Because it is occurring in pathologic condition like cardiac failure, right? Here also the myocardium is a stable tissue, therefore it cannot proliferate, right? Therefore hyperplasia cannot be seen in this condition, only we can see pathological hypertrophy. Next one, option C, proliferation of liver cells after transplantation. As we all know, usually liver has the ability to regenerate. Once we can resect a lobe of the liver, it would be regenerated again due to proliferation. And proliferation means what? Cell division. That means increase in cell number. So proliferation of liver cells after transplantation is an example of hyperplasia. It is an example of hyperplasia, and as it is compensating the liver lobe which has been resected, this is an example of compensatory hyperplasia, right? So the last option we are left with is your option D, uterus during pregnancy. This is your right answer because as we all know, in early stages of pregnancy, what happens? In early stages of pregnancy, the uterus grows in size, okay? So in early stages of pregnancy, usually the uterine growth, it occurs due to hyperplasia of the myometrium. Okay, it usually occurs due to hyperplasia of your smooth muscle cells of the uterus. Whereas in the late stages of pregnancy, that is after mid gestation, what happens? The uterine growth which occurs is predominantly due to the myometrial hyperplasia. Now the smooth muscle cells of your uterus will undergo hypertrophy, Okay, after mid gestation, the predominant mechanism for uterine size growth is what? It is your myometrial hypertrophy. So uterus is such an organ where we can see hyperplasia and hypertrophy both occurring at the same time, that is during pregnancy. But here if they ask you breast, okay, so please remember, if they ask you breast during puberty or during pregnancy, that would be the best answer. Okay, so please remember, there are two organs in the body in which there is simultaneous hyperplasia and hypertrophy. Those are your breast and uterus. Okay, breast during puberty and pregnancy, and next is your uterus during pregnancy. Both of these show simultaneous physiological hyperplasia and hypertrophy. Right, I hope this is clear to you now, and let's move further. And just remember guys, these types of questions have been asked again and again and again, so be sure of these questions, right? Moving further to our question number 2, which states thrombosis is initiated by. So let's see, thrombosis is what? Thrombosis is actually a clot formation, right? So thrombosis is due to aggregation of your platelets. So let's see now, first of all, option A, platelet activation. Option B, endothelial injury. Option C, coagulation cascade. And option D, vasoconstriction of vessels. So as we all know guys, thrombosis, for thrombosis there should be 3 primary abnormalities which are responsible. Right, for thrombus formation or for thrombosis, there are 3 primary abnormalities which are responsible for thrombus formation, and these 3 primary abnormalities were given by a scientist known as Dr. Rudolf Virchow. Therefore these are known as Virchow's triad. These 3 primary abnormalities for thrombus formation are known as what? They are known as Rudolph's or the Virchow's triad, right? And these 3 abnormalities are what? These are, first is your endothelial injury. Second is what? Stasis of blood flow, that is standstill of blood flow. And third is what? Third is hypercoagulability of the blood. So please remember, what are the 3 features of Virchow's triad? First is endothelial injury, second is stasis of blood flow, and third is hypercoagulability of the blood, right? These are the 3 features of your Virchow's triad which will lead to thrombus formation. The most important out of these 3 is your endothelial injury. So please remember, most important out of these 3 is your endothelial injury, because endothelial injury ke bina thrombus formation could not initiate. So please remember, the initiating factor or the most important factor for thrombus formation is what? It is your endothelial injury. So option B, endothelial injury, is your right answer, right? Please remember this. Then moving on to our question number 3, that states a 58-year-old man, okay, a 58-year-old man experienced chest pain 4 days ago with diaphoresis, which means excessive sweating, and dyspnea, right? The patient was diagnosed as a case of myocardial infarction. So the diagnosis has already been given in the question, that is myocardial infarction, MI. Which of the following microscopic change is most likely to be present? So which of the following microscopic change can we see in this condition? So first of all, what is our diagnosis in this condition? The diagnosis in this condition is myocardial infarction. So what usually happens in infarction? Infarction क्यों होता है usually? Infarction occurs due to prolonged ischemia. If the blood supply is cut off for a longer period of time, if there is prolonged ischemia, that can lead the tissue to be infarcted, right? Therefore the infarction could occur. So इसमें क्या हो जाता है? In cases of infarction, there is cell death, right? There is cell death. So the myocardial tissue dies. There is cell death. So this cell death usually occurs mainly by 2 mechanisms, as we have already discussed, either by necrosis or by apoptosis. But please remember guys, in cases of infarction, the cell death always occurs by the process of necrosis. So please remember, in cases of infarction, due to decreased blood supply due to ischemia, the cell death usually occurs always by the process of necrosis. It usually occurs by the process of necrosis. Important, right? There are different types of necrosis that we have, right? There can be coagulative necrosis, liquefactive necrosis, caseous necrosis, fibrinoid necrosis, or fat necrosis. All of these are different types of necrosis. Now they are asking which of these type of necrosis would be seen on a microscope in cases of myocardial infarction, right? So usually in cases of myocardial infarction or in cases of any of the parenchymal infarctions, so in cases of solid organs, ठीक है, जब भी कोई solid organ हो या कोई parenchymal organ हो, in these parenchymal or solid organs usually we see coagulative necrosis. So option A, coagulative necrosis is your right answer. So please remember guys, coagulative necrosis is usually seen in cases of infarction. Okay, all parenchymal organs will show coagulative necrosis. So infarction will show coagulative necrosis. What is the basic pathology of coagulative necrosis? Coagulative necrosis usually occurs due to protein denaturation. It usually occurs due to protein denaturation. Important one, right? And one more thing important over here is that the tissue architecture is preserved. Okay, the tissue architecture is usually preserved in cases of coagulative necrosis. It is usually preserved. Okay, important thing. Then next one is your liquefactive necrosis. In this what happens, there is liquefaction, right? Liquefaction of the tissue occurs. Okay, it is also known as colliquative necrosis. Liquefactive necrosis is also known as colliquative necrosis. This usually occurs in the which organ? It usually occurs in brain, and it also occurs in cases of pyogenic infections like pus forming infections. So please remember, liquefactive necrosis usually occurs in brain as well as in cases of pyogenic or pus forming infections, right? So please remember, what is the mechanism of liquefactive necrosis? The mechanism of liquefactive necrosis is enzymatic digestion. So please remember, liquefactive necrosis usually occurs with the help of enzymatic digestion. And one more important point, there is complete loss of tissue architecture. There is complete loss of tissue architecture in cases of liquefactive or colliquative necrosis, right? Tissue architecture is completely lost, right? So one more important type of necrosis is our caseous necrosis. Okay, so please remember, caseous necrosis is nothing but a special type of coagulative necrosis. Okay, by caseous we mean cheesy. So please remember, caseous necrosis is also known as cheesy necrosis because at the center of the necrosis, what we can see at the focus, okay, we can see some cheesy whitish material accumulated. Okay, so please remember, caseous or cheesy necrosis. It is usually seen in conditions like tuberculosis or syphilis. So please remember, caseous necrosis is usually associated with conditions like tuberculosis or syphilis. Whereas fibrinoid necrosis, this is again an important one. Fibrinoid necrosis is usually occurs due to immune complex deposition. That is, antigen antibody complexes are deposited. Where? In the vessel wall. So please remember, if in vessel walls the immune complex gets deposited, it would lead to which type of necrosis? It would lead to fibrinoid necrosis. And the examples of fibrinoid necrosis क्या याद रखोगे? So please remember, the most important examples of fibrinoid necrosis is PAN, that is polyarteritis nodosa, which is a type of vasculitis. And one more example is your rheumatic fever. In cases of rheumatic fever, usually in the heart you can see some Ashkoff nodules, and these Ashkoff nodules, which are a characteristic feature of rheumatic fever, these are also an example of fibrinoid necrosis. So fibrinoid necrosis कौन सी दो जगह पे दिखा? First was polyarteritis nodosa and second is rheumatic fever के Ashkoff nodules में, and it is due to immune complex deposition in the vessel wall. I hope this is clear to you. Now moving on to your next question, that is question number 4, which is Caspase cleaves the proteins at which residue? So it is asking Caspase proteins को कहाँ तोड़ता है, at which part of the residue? So please remember, Caspase, by the name itself we can remember this. Okay, so please remember, Caspase are what? So please remember, Caspases are your cysteine proteases. What are Caspases? Caspases are your cysteine proteases. These are enzymes which play a very important role in the process of apoptosis. Okay, apoptosis is a mechanism of cell death. It is a programmed cell death, right? So in cases of apoptosis, the main role is played by these cysteine proteases known as caspases. So how to remember this? So over here, C goes for your cysteine, right? ASP goes for your aspartic acid residues. Okay, so the cleavage occurs where? At the aspartic acid residues. Okay, and ases, it goes for your proteases, the enzyme. right? So please remember, by Caspase's name itself you can remember this. Caspases cleaves the protein as which residue? It cleaves the protein usually at option C, aspartic acid residues. And what are Caspases? These are cysteine proteases. क्या होता है? These are cysteine proteases which cleave the protein at aspartic acid residues. Please remember this, right? Important one. Now I will just throw some light on apoptosis over here. As we all know, guys, apoptosis is what? Apoptosis is a programmed cell death which usually occurs in two phases. The first phase being the initiation phase, whereas the second phase being the executioner phase. पहले phase में क्या होता है? Just initiation of apoptosis, whereas second phase में क्या होता है? Actual execution of the process. So in initiation phase, what happens? It is by two of the pathways. It can occur either by extrinsic pathway, okay, or it can also occur by a intrinsic pathway, right? Here the extrinsic pathway is also known as death receptor pathway. Extrinsic pathway is also known as a death receptor pathway, whereas the intrinsic pathway is also known as what? Intrinsic pathway is also known as mitochondrial pathway. Okay, intrinsic pathway is also known as mitochondrial pathway. Important one, right? So please remember, guys, extrinsic pathway को death receptor pathway क्यों बोला जाता है? Because it occurs due to activation of these death receptors. Okay, the ligands would combine with these death receptors, leading to activation of this extrinsic pathway, whereas intrinsic pathway is activated by a protein known as by an enzyme known as cytochrome oxidase. Okay, so intrinsic or the mitochondrial pathway is activated by the enzyme known as cytochrome C oxidase, which is usually located in where? It is usually located in the intermembranous space. Okay, cytochrome C activates the intrinsic or the mitochondrial pathway, which is located in the intermembranous space of your mitochondria, right? Now important क्या है इसमें याद रखना? So please remember, extrinsic pathway is activated by which caspase? This is very much important, right? Once the death receptors are activated, they activate which caspase? So please remember, once the death receptors are activated, they activate caspase number 8, which further carries the extrinsic pathway. They activate caspase number 8, whereas once this cytochrome C is activated, it activates which pathway? It activates which caspase? It activates caspase number 9. So please remember, extrinsic pathway is activated by caspase 8, whereas intrinsic pathway is activated by caspase 9. Okay, important. Whereas these are about your initiation phase. What about your executioner phase? So please remember, executioner phase is mostly taken care of by some caspases known as caspases 3, 6 and 7. So caspase 3, 6 and 7 are responsible for the executioner phase of apoptosis. Apoptosis के बारे में और दो चीज़ें याद रखना important है, on which questions have been asked, right guys? So please remember, what is the marker of apoptosis? So please remember, annexin 5 dye. Okay, so please remember, annexin 5 dye is the marker of your apoptosis. Okay, annexin 5 dye is the marker of your apoptosis. Whereas if we perform a HB electrophoresis, on an HB electrophoresis, apoptosis will show which pattern? So please remember, apoptosis shows step ladder pattern on a electrophoresis. Okay, on a electrophoresis usually apoptosis shows a step ladder pattern. Necrosis shows a smearing pattern. ठीक है, याद रखना है. So these are the few important points that you need to remember about apoptosis, right? Now moving on to our next question, question number 5, that states all below given necrotic changes are seen in the cytoplasm except. So what you need to rule out? You need to rule out some nuclear change, right? Either there can be changes in the cytoplasm or there can be changes in the nucleus. So here they are asking all of the changes are cytoplasmic except one. You need to find out the nuclear change which occurs in the phase of necrosis. So what do we mean by necrosis? Necrosis is what? Necrosis is a mechanism of cell death, right? But in pathological terms, necrosis usually means all the morphological changes that occurs in a cell after cell death. Okay, all the morphological changes that occur in a cell after cell death are termed as necrosis. So necrosis mein there can be some cytoplasmic changes and there can be some nuclear changes, right? So please remember this. What are the changes that we can see in the cytoplasm? So please remember, first of all, we can see increased eosinophilia. Okay, As we all know, cytoplasm is eosinophilic, that is pink in color. So we can see excess of pinkish appearance of the cytoplasm. This is known as increased eosinophilia. Second, we can see myelin figures. What are myelin figures? These are concentric lamellated figures formed due to broken down phospholipids. क्या होता है usually necrosis में? The cell membrane or the plasma membrane or the organellar membrane is broken down, okay, which is made up of phospholipids, and all these broken down phospholipids, they accumulate and form these concentric figures known as myelin figures, right? Important one. Next one, they can also lead to large fluffy pink amorphous densities. Okay, please remember, they can also lead to large fluffy pink amorphous densities. And what are these amorphous densities made up of? So please remember, these are nothing but your calcium protein complexes. So please remember, these calcium protein complexes are known as your large fluffy pink amorphous densities usually, right? So please remember. So what are all the cytoplasmic changes seen in necrosis? Increased eosinophilia, myelin figure formation, and large fluffy pink amorphous densities due to calcium protein deposition. Then what are the nuclear changes that we can see? So please remember, the first nuclear change that occurs usually is known as pycnosis. What do we mean by pycnosis? Pycnosis means clumping of chromatin. There is condensation of chromatin. This is known as pycnosis. After pycnosis, what happens? The nucleus gets fragmented, and this fragmentation of nucleus is known as what? Fragmentation of nucleus is known as karyorrhexis. Whereas finally what happens? This fragmented nucleus now finally leads to dissolution. There is dissolution of this fragmented nucleus, which is known as karyolysis. So the three nuclear changes seen in cases of necrosis are what? First is pycnosis, second is karyorrhexis, and third is karyolysis. Please remember one important point, guys. Pycnosis is one of the nuclear change which is common to both, that is necrosis as well as apoptosis. So pycnosis is seen in necrosis plus apoptosis in both of these conditions, right? So now let's go to the question once again. All below given necrotic changes are seen in the cytoplasm except, so increased eosinophilia is seen in the cytoplasm, myelin figures are seen in the cytoplasm, pycnosis, no, it is seen in the nucleus, whereas large fluffy pink amorphous densities are also seen in the cytoplasm. So the exception over here is option C, pycnosis, which is not a cytoplasmic, rather a nuclear change or the first change of necrosis in the nucleus, right? Important feature. Moving further to our next question, guys. Question number 6. Over here, a person was diagnosed as a case of viral hepatitis. The histopathological examination reveals presence of ground glass hepatocytes. This is your histopathological examination which is given. Okay, here you can see some ground glass hepatocytes. What do we mean by ground glass hepatocytes? The cell contains a transparent cytoplasm. Okay, so please remember, the cell contains usually a transparent cytoplasm leading to this ground glass appearance. So please remember, guys, ground glass appearance can also be seen in cases of necrosis, and it can also be seen in cases of apoptosis, right? It is seen in both. Ground glass appearance is also seen in necrosis and also in apoptosis, right? So which among the following factor will inhibit the underlying pathology? So first of all, we need to know what is the underlying pathology in this case. The person is suffering from viral hepatitis. Liver biopsy is given over here, which is showing some ground glass hepatocytes. The liver are showing us the ground glass appearance, okay? And usually what happens, the ground glass appearance is seen, but along with that क्या दिख रहा है यहाँ पे? The cell membrane is usually intact. Okay, the cell membrane or the plasma membrane कैसा है? It is usually intact. So please remember, in cases of necrosis, usually the cell membrane is disrupted. The cell membrane or the tissue architecture is completely lost. Whereas in apoptosis, the cell membrane is intact. In cases of apoptosis, the cell membrane is intact. And in cases of viral hepatitis, we know the hepatocytes usually undergo apoptosis. And once they undergo apoptosis, they lead to formation of some apoptotic bodies. And these apoptotic bodies give us this ground glass appearance. And this ground glass hepatocytes or apoptotic bodies are now known as what? They are known as councilman bodies. So what are these bodies seen in this histopathological examination? These are your councilman bodies seen in cases of acute viral hepatitis, right? These are your councilman bodies. So now we are clear that what is the basic underlying pathology? The basic pathology over here is apoptosis. So now which are the factors which will inhibit apoptosis? That you need to know, right? Which among the following factors will inhibit apoptosis? For that purpose, let's see some pro-apoptotic factors and some anti-apoptotic factors, right? So once there is some chemotherapy or radiotherapy, or there is some DNA damage, or there are targeted therapies or some oncogene activation that leads to some stress or the injury to the cell, once there is stress or injury to the cell, the pro-apoptotic molecules would be activated as the cell is damaged now. Therefore the cell will undergo death by this programmed cell death mechanism known as apoptosis. Therefore these pro-apoptotic factors are to be activated. And which are all the pro-apoptotic factors? So please remember, these are your BID, BIM, PUMA, NOXA. Okay, these are your activator factors, that is BID, BIM, PUMA and NOXA. Some of the factors will sensitize apoptosis. These are your BAD, BIC, NOXA, HRK, PUMA and BMF. And some of the factors would now cause effector. Okay, they will cause action, right? They will lead to effector these are known as effector pro-apoptotic factors. And which are all these effector pro-apoptotic factors which will cause cytochrome C release? So please remember, here all in cases of apoptosis we have already seen, in cases of intrinsic pathway of initiation phase, what happens? There is cytochrome C release which causes all the damage, right? So this cytochrome C is released due to what? These are released due to the activation of effector pro-apoptotic factors. And what are these effector pro-apoptotic factors? These are BAX, BAC and BOC. Okay, all of these together are known as your pro-apoptotic factors. Now which are the anti-apoptotic factors? The ones you can see over here in red are known as your anti-apoptotic factors, which will try to stop this process. And these anti-apoptotic factors, it is easy to remember them because most of them contain L in their name. Okay, most of them contain L in their name, that is BCL2, BCLXL, MCL1, BCLW and BFL1. Okay, these are some important ones. Now let's get back to our question. So a person was diagnosed as a case of viral hepatitis. HPE shows ground glass hepatocytes. Which among the following factor will inhibit the underlying pathology? Underlying pathology is apoptosis. So which among the following will inhibit apoptosis? That is, which among the following is an anti-apoptotic factor? We have seen BAX, PUMA and P53. So please remember guys, P53 is also a pro-apoptotic factor. It kills the cell if it is defective. Okay, so it is also a pro-apoptotic factor. The only exception over here which contains L in their name is option C, BCL2. As we all know, BCL2 is the exception over here. BCL2 is an anti-apoptotic factor, right? Moving on to our next question guys, question number 7, which states which among the following pigment is found in the brown atrophy of myocardium. Okay, so what is this? This is your gross appearance of your heart or gross appearance of your myocardium. And what you can see brownish discoloration of your myocardium over here. And this brownish discoloration of your myocardium is due to what? It is due to brown atrophy of the heart. And this brown atrophy of the heart is due to what? This brown atrophy of the heart is due to some pigment accumulation. And there is some pigment which has accumulated in the myocardial tissue which has led to this brownish discoloration of the heart. Okay, so please remember, usually brown atrophy of myocardium or brown atrophy also occurs in liver tissue. So this brown atrophy is usually associated with what? It is usually associated with aging. Okay, senility. जैसे जैसे age बढ़ती है, pigment accumulation can start in various tissues of the body. Okay, so this brown atrophy is usually associated with aging. And which is the pigment which usually accumulates with increasing age? So please remember, option C, lipofuscin is the pigment which usually starts accumulating with increasing age, right? Lipofuscin is also known as lipochrome. Okay, so this is an endogenous pigment which is produced inside the body itself. Okay, lipofuscin or lipochrome. This is a brown colored pigment leading to brown atrophy of your different tissues. Okay, this is also known as your wear and tear pigment. And why it is known as your wear and tear pigment? So please remember, it usually deposits at the sites where there is free radical injury. It usually deposits at sites where you can find free radical injury. जहाँ जहाँ पे free radical injury चल रही है, वहाँ पे lipochrome or lipofuscin would go and deposit or accumulate. Okay, so please remember, this is your lipofuscin. Okay, it is a physiological pigment. It is a physiological brown colored pigment. Now next one over here is your homosiderin, and homosiderin is also a brown colored pigment, right? So please remember, homosiderin is also a brown colored pigment. right? It usually deposits at various tissues in the body, either at myocardium or in the kidneys or in the liver, okay? At various places it can deposit. So this is also a brown colored pigment, but please remember it is a pathological pigment. Homosiderin usually accumulates in a pathological way. It usually accumulates in a condition known as homosiderosis. It usually accumulates in a condition known as homosiderosis, which is due to iron excess. So please remember, homosiderin is an iron containing pigment. Okay, homosiderin is usually an iron containing pigment. It usually deposits or accumulates in conditions like homosiderosis, where there is iron excess or iron overload. Okay, so it is a pathological brown pigment which is accumulated inside the body. Then melanin. Melanin is also an endogenous pigment, and please remember it is the only black colored endogenous pigment which accumulates inside the body. The only black colored endogenous pigment which can accumulate inside the body is what? Melanin. Okay, it is your melanin. One more important point to remember about melanin is what? The stain used for melanin is known as what? So please remember, the stain is important. The stain used for melanin is known as Masson's Fontana. The stain used for melanin is known as what? It is known as Masson's Fontana. And one important point about carbon also. So please remember, carbon is the most common exogenous black pigment which is accumulated. Okay, so please remember, carbon is the most common exogenous black pigment which is accumulated inside the body. It leads to a condition known as anthracosis, which we have already discussed in respiratory pathology, right? Moving further to our next question, question number 8, that states, a 5-year-old child was experiencing repeated episodes of infection and enlarged lymph nodes. On examination, gray hair with hypopigmentation was observed. The most likely pathology is, so what we can see over here, there is a 5-year-old child, right, experiencing repeated episodes of infection. Along with that, we can find enlarged lymph nodes, that is, there is lymphadenopathy, right? Okay, so this can be in conditions, repeated episodes of infections or lymphadenopathy usually can be seen in conditions where the WBCs are not in adequate number, or the WBCs are defective, right? That will lead to repeated episodes of infection, right? But along with that, what have they mentioned? They have also mentioned that on examination, the child shows gray hair along with hypopigmentation. And usually, gray hair along with hypopigmentation in children is usually due to defective melanocytes. And defective melanocytes are seen in which condition? Defective melanocytes are seen in condition known as albinism. It is seen in what? Albinism. So the three features that we can see over here in this condition is what? Repeated episodes of infection along with lymphadenopathy along with albinism. So what is the most probable cause of this condition? Can you anybody tell me? So please remember, the provisional diagnosis in this condition is what? The provisional diagnosis is a condition known as Chediak-Higashi syndrome. Okay, the condition is known as Chediak-Higashi syndrome. And what happens in Chediak-Higashi syndrome usually? So please remember, in Chediak-Higashi syndrome, there is no phagolysosomal fusion. So if the WBCs want to kill a bacteria or any of the offending agent, what it shall do? It shall form a phagolysosome. Okay, and then the phagocytosis would properly occur. Then the killing of the bacteria occurs, right? So, but in this condition known as Chediak-Higashi syndrome, there is no phagolysosomal fusion. Phagosome or lysosome fuse nahi kar pate hai, right? So there is no phagolysosomal fusion, and this occurs due to which process? So please remember, what is the underlying pathology responsible for this? So please remember, usually phagolysosomal fusion is the responsibility of some regulatory proteins. And what are these regulatory proteins known as? These regulatory proteins are known as docking proteins. Okay, so please remember, these regulatory proteins are known as docking or list proteins. Docking or list proteins, which are encoded by the list gene, right? If the list gene undergoes mutation, or if these docking or list proteins are defective, any of this can lead to Chediak-Higashi syndrome, okay, where there would be no phagolysosomal fusion, and therefore the WBCs cannot act properly, leading to repeated bouts of infection in this child. Along with albinism can be seen, right? Along with some neurological manifestations can also be seen due to defective myelination, and also we can see repeated episodes of bleeding in this child, right? So this is your Chediak-Higashi syndrome. So what is the answer now? The most likely pathology in this Chediak-Higashi syndrome is what? Defective docking proteins. So option B, defective docking proteins, is the right answer over here. We can see over here one more thing, that is defective NADPH oxidase myeloperoxidase halide system. Okay, this NADPH oxidase MPO or myeloperoxidase halide system is the most effective bactericidal system used by neutrophils for killing the bacteria. Okay, this is the most effective bactericidal system used by whom? Used by which cells? Used by neutrophils. So neutrophils को अगर बैक्टीरिया को किल करना है, the most effective mechanism they have is this NADPH oxidase myeloperoxidase halide system, also known as oxygen dependent killing. इसी मेथड को क्या बोला जाता है? This is also known as oxygen dependent killing. But if this NADPH oxidase myeloperoxidase halide system is itself defective, तब क्या होगा? It would lead to some disorder. And what is this disorder known as? It is known as chronic granulomatous disease or chronic granulomatous syndrome. So please remember, if NADPH oxidase enzyme is defective, it can lead to a condition known as chronic granulomatous disease. Okay, so please remember, they can ask you pattern of inheritance. Okay, so please remember, Chediak-Higashi syndrome is what? It is autosomal recessive. Chediak-Higashi syndrome is autosomal recessive, whereas chronic granulomatous disease is X-linked recessive. Chronic granulomatous disease is X-linked recessive. Okay, in this case also there would be repeated episodes of infection again, right? There would be granuloma formation, and the name itself you can see chronic granulomatous disease, right? And one important thing that was asked earlier, which is the diagnostic test for CGD, which is the diagnostic test used in cases of chronic granulomatous disease. So please remember guys, the diagnostic test which is usually used is known as nitroblue tetrazolium test, and it is very important. Okay, nitroblue tetrazolium test is used for diagnosis of your chronic granulomatous disease. So please remember, nitroblue tetrazolium test is positive in normal individuals, whereas in cases of chronic granulomatous disease, this nitroblue tetrazolium test would be negative. ये important बात याद रखनी है. It is usually negative in cases of CGD, right? One more just important feature, this superoxide dismutase gene mutation, right? Superoxide dismutase is usually used for what? It is usually used for free radical inactivation, right? So superoxide dismutase usually inactivates the free radicals, and the superoxide dismutase gene, if it undergoes mutation, this can lead to a condition known as what? This can lead to a motor neuron disease, and this motor neuron disease is known as ALS, that is amyotrophic lateral sclerosis, which was the condition which was seen in Stephen Hawking's, right? So please remember this. Moving further to our question number 9, which molecule is responsible for diaphoresis? Okay, so please remember guys, what is diaphoresis? To understand that, we need to understand inflammation, right? So inflammation is mainly of two types. It is acute inflammation and it is chronic inflammation, right? Of sudden onset and shorter duration, it is acute inflammation. Okay, of longer duration, okay, and prolonged onset, it is your chronic inflammation, right? So usually we talk about acute inflammation. So what happens in cases of acute inflammation, guys? In cases of acute inflammation, there are some vascular events which happens within the vessel, and there are some cellular events which happen outside the vessels, mostly at the cell level, right? Which are the vascular events? So please remember, the first vascular change or the first change overall seen in cases of acute inflammation is your transient vasoconstriction. Question can be asked on this, which is the first change seen? The first change seen is transient vasoconstriction. What do we mean by transient? For a shorter duration of time. So first change that we can see is your transient vasoconstriction, which is followed by vasodilation, vasodilation. This vasodilation would cause increased vascular permeability. This vasodilation would now lead to increased vascular permeability. So please remember this, okay? And this increased vascular permeability is considered the hallmark of acute inflammation. The hallmark of acute inflammation is what? Increased vascular permeability. And the first change is what? Transient vasoconstriction, right? After this increased vascular permeability, what happens? That the fluid or the plasma inside the vessel starts leaking out of the vessels due to this increased permeability. And this plasma as it leaks out of the vessel. This is known as what? This is known as exudation. This is known as exudation, right? And exudation usually occurs in the adjacent or the surrounding tissues, leading to edema. There would be extravasation of this fluid and it would accumulate in the surrounding or the adjacent tissues, leading to edema. Why it is known as exudate? This fluid is known as exudate because it is high in or rich in proteins and cells. Please remember, this fluid, as it is high in proteins or rich in proteins and cells, it is known as exudate. Okay, it has a high specific gravity, right? So please remember, therefore it is known as exudation. So this is what happens usually in cases of acute inflammation, right? Moving further, after this what happens is sorry, after this, due to this exudation, the fluid has been leaked out of the vessel. Now there would be increased viscosity of the blood, and this increased viscosity of the blood would lead to stasis of the blood flow, right? Now there are cellular events which start to occur. What happens now at the cell level, we'll see. Okay, usually after stasis of the blood flow, what happens, the leukocytes or the WBCs which were moving in the center of the blood vessels, now they start to marginate. Now they start to come towards the margin of your blood vessels or towards your endothelial cells. Okay, and this process is known as margination. Okay, after margination, what happens, these leukocytes or WBCs starts rolling on the endothelial cells. So this process is known as rolling. Then they adhere to the endothelial cells, known as adhesion. Okay, and then finally they lead to transmigration. And what do we mean by transmigration? So please remember, transmigration is the same as diaphoresis. So please remember, transmigration or diaphoresis is the movement of these neutrophils. Okay, usually in cases of acute inflammation, क्या होता है? So please remember, the most important cells in acute inflammation are your neutrophils, and the most important cells in chronic inflammation are your monocytes. So please remember, acute inflammation, neutrophils, chronic inflammation, these are your monocytes, macrophages. Also in chronic inflammation we can see lymphocytes also. Okay, lymphocytes also play a very important role in cases of chronic inflammation. Yaad rakhna. So usually in cases of acute inflammation, what happens, there is diaphoresis or transmigration, which is movement of these neutrophils across the cell wall. Now they move out of the vessel, right? And then what happens, these neutrophils now get attracted towards the site where there's the offending agent. जहाँ पे बैक्टीरिया है उस तरफ जाते हैं उसको मारने के लिए, right? And this process is known as chemotaxis. And lastly, once they go to that site, they will kill the bacteria, and this is known as the process phagocytosis, right? So these are all the vascular and cellular events which usually occurs in cases of acute inflammation, right? So now for these different stages of vascular or cellular events, some of the molecules are responsible. So please remember some important types of molecules that you need to know. First are your selectins. Okay, so please remember, selectins are also known as CD62, right? Selectins are also known as CD62. Right, so selectins usually, or CD62, they are of three types. E-selectin present on the endothelium, P-selectin present on platelet and endothelium, and L-selectin present on the leukocytes or WBCs, mainly on the neutrophils, Okay, these are your three types of selectins. And second molecules are your integrins. Second molecules are what? Second molecules are your integrins. There are two types of integrins, beta-1 integrin and beta-2 integrin. Beta-1 integrin is known as VCAM1, that is vascular cell adhesion molecule 1. Okay, beta-1 is also known as VCAM1, whereas beta-2 integrin is known as ICAM1, that is intercellular adhesion molecule 1. Okay, so beta-2 is also known as ICAM1. So please remember guys, this selectins and integrins, they together are responsible for rolling and adhesion. So please remember, this selectins and integrins are responsible for rolling and adhesion of these cells or your neutrophils. Important one. Okay, next cell is your PECAM1. Next cell is your PECAM1, that is platelet endothelium cell adhesion molecule. And this platelet endothelial cell adhesion molecule 1 is also known as CD31. It is also known as CD31, which is responsible for the process of diaphoresis. Now you know, okay, these are the three important ones that you need to know: selectins, integrins, and PECAM1. Right? So over here, what is the question? Which molecule is responsible for diaphoresis? So please remember, PECAM1, that is platelet endothelial cell adhesion molecule 1, also known as CD31, is responsible for diaphoresis or transmigration. So option A, CD31 is your right answer over here. Moving further to our question number 10, a patient was diagnosed as a case of papillary carcinoma of thyroid. Okay, on PCTs usually a lot of questions have been asked in the recent years, so read it with utmost care. Okay, so papillary carcinoma of thyroid, the pathologist states presence of psammoma bodies and dystrophic calcification. The level of calcium in serum will be. So now let's see what is this condition first. Okay, so this is your papillary carcinoma of thyroid, and this is the histopathological examination which has been given. Okay, and these concentric rings of calcification which are seen over here, these are nothing but your psammoma bodies. Okay, these are your concentric rings of calcification. So please remember, psammoma bodies are nothing but your concentric or lamellated rings of calcification. These are your psammoma bodies, and psammoma bodies are associated usually with many tumors, right? So psammoma bodies are usually seen in which type of calcification? Usually we have two types of calcification, either dystrophic calcification or metastatic calcification. So here they have already mentioned that there is presence of psammoma bodies and there is dystrophic calcification. So please remember, psammoma bodies are usually seen in cases of dystrophic calcification. Okay, and now let's see what happened in cases of dystrophic calcification. So please remember guys, usually D for dystrophic calcification and D for dead, degenerated or damaged tissues. So please remember guys, usually dystrophic calcification would occur in what? It would occur in dead, degenerated or damaged tissues. Important point. Okay, please remember this. Then next one, the metastatic calcification, it would occur where? So please remember, metastatic calcification, it usually occurs in living normal tissues. It usually occurs in living and normal tissues of the body. Right, so please remember this. Now dystrophic calcification mein the serum calcium levels are usually normal. In cases of dystrophic calcification, the serum calcium levels are usually normal, whereas in cases of metastatic calcification, the serum calcium levels are what? They are usually elevated. In cases of metastatic calcification, the serum calcium levels are usually elevated. This is important, right? What is the most common cause of metastatic calcification? So please remember, the most common cause of metastatic calcification is your primary parathyroid adenoma, or you can say primary hyperparathyroidism. Okay, so please remember, primary parathyroid adenoma is the most common cause of metastatic calcification, right? So these are your two types of calcifications, right? So please remember, in dystrophic calcification, serum calcium levels are normal, whereas in metastatic calcification, the serum calcium levels are elevated. In the question, they have asked about what? They have asked about dystrophic calcification. Therefore, the level of calcium in serum would be absolutely normal. So option C is your right answer over here, right? Important one. Please remember this, right? Now moving further to our next question. Before that, just remember two important stains used for calcification, guys. So please remember guys, the two important stains which are usually used for calcifications are what? It is your von Cosa stain and your Alzarine red stain. So please remember, the two important stains used in cases of calcification are your von Cosa stain and your Alzarine red stain. Just a minute guys. Now moving further to our next question guys, that is question number 11, okay, which states what? If serum levels of complement C1, C2 and C4 are normal and serum levels of complement C3, C5 to C9 are decreased, it indicates activation of which complement system? Okay, it is easy guys. So please remember, usually serum levels of complement कब कम होंगे? When they are being used. Okay, so please remember, whenever these complements are being used, therefore their levels would be decreased. So what they have stated over here, serum levels of complement C3 and C5 to C9 are being decreased, whereas serum levels of C1, C2 and C4 are absolutely normal. So they are asking which complement pathway has been activated in this regard. So let's see first of all the different types of complement activation systems or pathways. So as we know, there are three pathways of complement system, right? So there is a classical pathway, there is a mannose banding lectin pathway, and there is a alternate pathway, right? These are the three pathways of complement activation. Now, first what happens, usually the classical pathway is activated by an antigen antibody complex. Whenever there is an immune complex formation, this classical pathway or antigen antibody complex whenever there is antigen antibody complex formation, the classical pathway would be activated. Once this classical pathway is activated, it would lead to activation of C1 complement, C2 complement, and then the C4 complement, right? Usually same occurs in mannose binding lectin pathway, but this time it is not the antigen antibody complex, rather it is the microorganism itself which causes activation of the mannose binding lectin pathway, which further in turn activates the C1 complement, C2 complement, and the C4 complement, right? So please remember, in classical and lectin pathway, C1, C2 and C4 are being used, okay, they are being used, whereas in cases of alternative pathway, the C1, C2 and C4, these complements are not used. It directly goes to the next step, okay? Alternate pathway directly goes to the next step, which is the activation of complement C3, activation of C3, okay? So what happens in classical lectin, this complex which has been formed, that is C4b and C2a, it activates C3, whereas in cases of alternate pathway, it directly activates C3 complement, right? So please remember, the common junction is where? The common junction is C3 complement, okay? So C3 complement का क्या होता है? C3 complement once it is activated, it would separate into C3A and C3B, where C3A would be used up in inflammation, whereas C3B would work as an opsonizer. What is opsonizer? So please remember, opsonization is a process which is responsible for phagocytosis. So please remember, opsonization is a process which is responsible for phagocytosis, and the most important opsonizer in the body is C3B. Most important opsonizer in the body is C3B. This question has been repeated twice, so please remember, the most important opsonizer in the body is C3B, whereas this activated C3B will now activate C5 complement, okay? It will activate C5 complement. Again, C5 is it was separated into C5A and C5B. C5A is responsible for inflammation, and it is responsible to remember about C5A because it is the most important chemoattractant. As we have seen in cases of acute inflammation, what happens? There is chemotaxis, okay? Chemotaxis is what? Migration of these neutrophils towards the offending agent, and this chemotaxis is mediated by these chemoattractants. Neutrophils को कैसे पता चलता है वहाँ तक जाना है? Because these chemoattractants call them over there, okay? And the most important chemoattractant in the body is C5A, right? Whereas the C5B which is left now, this C5B will lead to activation of this membrane attack complex, and membrane attack complex is made up of what? It is made up of C5B to C9, okay? It is made up of C5B, C6, C7, C8 and C9, and this membrane attack complex would finally lead to lysis or destruction of the offending agent of the bacteria, right? Important one. Moving further moving back to our question now. What was the question? Serum levels of complement C1, C2 and C4 are normal. That means they are not being used. Whereas serum levels of complement C3 and C5 to C9 are decreased. Okay, that means C3, C5 to C9 are being used. As we all know, C3, C5 to C9 are used in every pathway, all of the pathways. But one pathway is such in which C1, C2 and C4 were not used. And what was that pathway? That was your option C, alternate complement pathway, right? In that, actually the pathway was directly started from C3 activation, right? So please remember, in cases of alternate complement pathway, C1, C2 and C4 complements are not being used. Now moving on to our question number 12, which states all below given are pro-inflammatory cytokines except. So you need to tell which of the following is an anti-inflammatory cytokine. So they have said what? All of the below given are pro-inflammatory, which will help in inflammation, except one which is anti-inflammatory, which will stop the inflammation, right? So let's see. First of all, cytokines are what? Cytokines are usually freshly formed chemical mediators. So please remember, usually cytokines are freshly formed. These are freshly formed chemical mediators, right? These are freshly formed chemical mediators. There are different types of cytokines like interleukins, okay? And there are different types of interleukins responsible for different processes. Interleukin 1 is known for what? It is known for causing fever. So please remember, interleukin 1 has a role in fever. Whereas interleukin 5 has a role in activation of what? It has a role in activation of eosinophils. It has a role in activation of eosinophils. Eosinophils are usually used in which condition? As we know, neutrophils are used in acute inflammation. Okay, in chronic inflammation, either we use monocytes or lymphocytes, whereas eosinophils are usually used in conditions like allergic conditions like bronchial asthma. So in any of the allergic conditions, which are the cells responsible for causing inflammation, these are your eosinophils. Important. Okay, so interleukin 5 is responsible for activation of these eosinophils. Interleukin 8 is responsible for activation of neutrophils. In cases of acute inflammation, activation of neutrophils is the responsibility of interleukin 8. Some more important interleukins that you need to know. Interleukin 2 is responsible for activation of natural killer cells. Okay, natural killer cells are usually seen in cases of viral infections. Okay, and whenever there is a viral infection, natural killer cells induce a phagocytic mechanism against these viral cells. Okay, and these natural killer cells are activated by what? They are activated by interleukin 2. Interleukin 6 will activate plasma cells, which will produce antibodies, right? So it would produce antibodies further, right? And one more important interleukin that we have already discussed in respiratory pathology, that was interleukin 4. Interleukin 4 is responsible for class switching or isotype switching. So please remember, interleukin 4 is responsible for class switching or isotype switching. Usually, as we all know, the most abundant antibody in the body is what? It is your IgM antibody. But in cases of allergic infections, this IgM antibody won't work. Therefore, it is to be converted to another antibody, that is IgE antibody. And this conversion of IgM to IgE antibody or interconversion of any of the antibodies is known as class switching or isotype switching, which is the responsibility of interleukin 4. Okay, so all of these interleukins that we have studied till now, they are in one way or the other helping inflammation. Okay, all of these are pro-inflammatory interleukins or pro-inflammatory cytokines, whereas there are two anti-inflammatory interleukins which act against inflammation, which help in stopping the inflammation, and these are interleukin 10 and interleukin 13. So please remember, interleukin 10 and interleukin 13 are anti-inflammatory cytokines. Okay, so option C, interleukin 10 is the right answer over here. Moving further to our next question, question number 13. Here it states, the below given multinucleated giant cells will be seen in all the following conditions except. So they are asking the below given giant cell. Usually on the histopathological picture that we have here, we can see a giant cell over here. Okay, this multinucleated giant cell is seen in all these conditions except one. So in which condition it is not seen, let's see. But before going on to the actual question, let's discuss what are the different types of multinucleated giant cells. So first of all, what happens in cases of chronic inflammation? Usually in cases of chronic inflammation, as we all know, there is granuloma formation. What happens? There is a granuloma formation. And what is this granuloma made up of? So please remember, granuloma is usually made up of some sleeper shaped cells. It is usually made up of some sleeper shaped cells known as epithelioid cells. These are known as your epithelioid cells. Then it has some lymphocytic infiltrate around it. Okay, there are some lymphocytic infiltration around these epithelioid cells, and finally interposed in between are some multinucleated giant cells. Okay, these are some multinucleated giant cells, and these multinucleated giant cells are nothing but modified monocytes. Okay, once these monocytes are modified, these become your multinucleated giant cells. And which is the most important molecule which activates these monocytes? So please remember, the most important molecule responsible for granuloma formation is interferon gamma. The most important molecule responsible for granuloma formation is what? Interferon gamma. Remember this. Okay, question has been asked on this. Now, there are three types of giant cells which can be formed after monocyte modification. Either there can be a Toton giant cell, either there can be a Langhans giant cell, or a foreign body giant cell. So what is the difference? So please see, in cases of Teuton giant cells, we can find at the center of the cell some multiple vesicles which are fluid with lipids. Okay, we can find some multiple vesicles. Okay, at the center, see, there are multiple vesicles. These are usually filled with what? These are usually filled with lipids or fats. And this is seen in which condition? These Teuton giant cells are usually seen in a condition known as juvenile xanthogranulomatosis. It is usually seen in a condition known as juvenile xanthogranulomatosis. Whereas the second type of giant cells are what? These are your Langhans giant cells. These Langhans giant cells, इनका characteristic feature क्या है? These have this nucleus arranged in a peripheral fashion. These Langhans giant cells have nucleus in a peripheral arrangement or a horseshoe arrangement. इसका nucleus कैसे arranged है? इसका nucleus is arranged in a peripheral fashion or a horseshoe fashion. And usually these Langhans giant cells are seen in some infective conditions or in some non-infective conditions, right? They are usually seen in immune granulomas. Wherever we can see immune granulomas, we can find Langhans giant cells, okay? So some non-infective conditions like sarcoidosis, Crohn's disease, Wegener's granulomatosis, Church-Strauss syndrome, okay, or giant cell arteritis, also known as temporal arteritis, chronic granulomatous disease that we have already discussed due to defective NADPH oxidase enzyme. Then apart from this, some tumors like Hodgkin's lymphoma or seminoma. In all these non-infective conditions, we can see this Langhans giant cell. Along with that, they are also seen in some infective conditions like tuberculosis, syphilis, right, or malaria or cat scratch disease. So please remember, in these infective conditions also we can find this Langhans giant cells. As we all know, usually in cases of tuberculosis we have a caseating granuloma that is associated with cheesy necrosis at the center of the granuloma, whereas in cases of sarcoidosis or Crohn's disease we have a non-caseating granuloma which does not have any kind of caseous or cheesy necrosis at the center of the granuloma, right? This is the basic difference. Then one more feature, malaria mein there is a characteristic type of granuloma which is seen, okay, in cases of cerebral malaria, which is caused usually due to falciparum, Plasmodium falciparum. The granuloma which is seen is known as what? The granuloma seen in cerebral malaria is known as Dirk's granuloma. Whereas in cat scratch disease also we have a characteristic type of granuloma seen, and that is a star-shaped granuloma known as stellate granuloma. In cat scratch disease or in cases of lymphogranuloma venerum, we can see a characteristic granuloma which is star-shaped known as stellate granuloma, right? Important two granulomas that you need to remember. Now moving on to a last type of giant cells, those are your foreign body giant cells. And these foreign body giant cells में इसमें क्या दिख रहा है? There is a haphazard arrangement of nucleus. So nucleus कहीं भी बिखरा हुआ है, okay, फैला हुआ है पूरे cytoplasm में. So please remember there is a haphazard arrangement of nucleus in this foreign body giant cells, and these are usually seen in non-immune granulomas. These foreign body giant cells are usually seen in non-immune granulomas in conditions where there are foreign body reactions, like in IV drug abusers, or also you can see this in conditions like pneumoconiosis, like silicosis, asbestosis, anthracosis, berylliosis, okay, all these conditions you can see foreign body giant cells. Now going back to our question now, the below given multinucleated giant cells will be seen in all of the following conditions except. Now let's first see which is the type of giant cell that we have in the picture right here. So in this picture, what you can see, in this picture, we usually can see, we usually can see a nucleus which is what? We usually can see a giant cell which has peripheral arrangement of the nucleus, right? We have a peripheral arrangement of the nucleus, and it is what? It is usually a Langhans giant cell. It is usually a Langhans giant cell, right? And Langhans giant cell is usually seen in infective conditions like tuberculosis and cat scratch disease, and it is also seen in conditions like non-infective conditions like sarcoidosis. So the only condition in which Langhans giant cell would not be seen is option C, asbestosis, which is a foreign body reaction in which we can see foreign body giant cells in which there would be haphazard arrangement of the nucleus, right? Now moving on to our question number 14, which states sickle cell anemia is an example of, right? And they have given what? Nonsense mutation, missense mutation, silent mutation, and frame shift mutation, okay? So what do we see in sickle cell anemia usually? Sickle cell anemia mein there is a point mutation. Itna to hame pata hai, right? In sickle cell anemia usually we have a point mutation, and nonsense, missense, and silent mutation are all types of point mutation, whereas frame shift mutation is not a type of point mutation, so it is easily ruled out from this, right? So now in sickle cell anemia there is point mutation. So what happens in this? Okay, at the beta globin chain, in the beta globin chain at 6th position, okay, in beta globin chain at the 6th position, what happens? Usually there is glutamic acid at the 6th position, but what happens? This glutamic acid is replaced by valine at the 6th position of beta globin chain. Usually this glutamic acid is replaced by valine at the 6th position of beta globin chain, which leads to sickle cell anemia. So glutamate goes and valine is welcome. This is how we remember it, right? So now let's first see these different types of mutations so we can easily understand sickle cell anemia over here, right? So first of all, this is your normal codons we can see over here. Okay, so this is your normal sequence of codons. These codons actually co-encode for different types of amino acids. But what happens if one of the nucleotide in this codon is changed? Okay, यहाँ का जो GCC था normally, it is changed to GCT now. But this C has been replaced by T. But previously it was encoding for alanine. Now also it is encoding for alanine. So if does any change has occurred? No, we cannot see any change. ठीक है, कोई change नहीं हुआ है in the basic sequence. Therefore, this is known as a silent mutation. This is known as a silent mutation. No change is seen. Okay. Then second one is your nonsense mutation. What happens in nonsense mutation usually? यहाँ पे क्या था? This codon was containing TGC nucleotide, but now the mutated codon is containing what? TGA nucleotide. Because of this A now, what happens? This codon is not making a sense at all. This codon is not making any sense, and therefore the sequence has been stopped. Okay, the sequence has been stopped. This is not encoding any of the amino acids. Okay, this is not encoding any of the amino acids, and therefore it is known as nonsense mutation. It does not make any sense. Then the third one is your missense mutation. What happens in this? Usually there was TGC now, which has been replaced by GGC. The T has been replaced by G nucleotide over here, right? Previously it was encoding for cysteine, but now it is encoding for arginine. So the amino acid has been replaced. The sequence will change now, therefore it wouldn't make any sense. Therefore this was known as your missense mutation. Okay, this is known as your missense mutation क्योंकि गलत amino acid आ गया यहाँ पे, right? Important one. Now this is your frame shift mutation, जहाँ पे frame shift हो जाती है either due to deletion of one nucleotide or due to insertion of one more nucleotide or due to insertion and deletion both, right? So please remember this. Now coming back to our question, what was it? Sickle cell anemia is an example of. We have already discussed it is an example of point mutation where what happens usually, the beta globin chain at the 6th position is being replaced by what it usually contains glutamic acid, which has now been replaced by valine. So ये भी hemoglobin usually बनाएगा. Okay, it will make hemoglobin, but this time the hemoglobin which would be formed would be what? The hemoglobin which is formed usually would be a defective hemoglobin known as a sickled hemoglobin or HbS. Okay, sickled hemoglobin would be formed, and this is an example of what? Option B, missense mutation. This is an example of missense mutation. ठीक है, यहाँ पे प्रोटीन बना, therefore it cannot be a nonsense mutation. Okay, यहाँ पे hemoglobin normal रहा क्या? नहीं रहा. Okay, therefore it cannot be a silent mutation, right? Moving further to one last question, that is question number 15. The below given pedigree chart is an example of which pattern of inheritance? So the below given pedigree chart shows what? So please remember guys, usually pedigree charts कभी कभार आ जाते exam में. It is important to know at least the important patterns of inheritance by the pedigree chart. Okay, so pedigree chart में the circle denotes a female. Circle denotes a female. A square denotes a male. Okay, if there is a darkened circle, it denotes a affected female or a deceased female. If there is a darkened square, it denotes a affected male or a deceased male. Half circle अगर colored है, that means there is a carrier female, and half square अगर colored है, that means there is a carrier male, right? Usually mostly males are not carriers in most of the conditions, females are carriers in most of the conditions, right? Please remember this now. So they are asking the below given pedigree chart shows which pattern of inheritance. So what we can see in this pedigree chart, first of all, okay, here we can see that the mother is affected, right? The female is affected, and the progeny or the offsprings, जितने भी बच्चे हैं, okay, whether these are girls or whether these are boys, all of them are affected. That is 100% of the progeny or 100% of the offsprings are affected. So if a mother is affected and it transmits she transmits the disease to all the offsprings, that is 100% of the offsprings, this is a what? This is which pattern of inheritance? This is a non-Mendelian pattern of inheritance known as option B, mitochondrial inheritance. So please remember guys, we usually receive our mitochondria from our mother. Papa se nahi aata, maa se mitochondria aata usually. Therefore, all the mitochondrial associated diseases will be coming from your mother directly. Okay. So if mother is affected, all the 100% of the progeny would be affected. This is a case of mitochondrial inheritance. The most common disorder associated with mitochondrial inheritance is what? It is your MELAS. Most common. This question has been asked. Most common disorder associated with mitochondrial inheritance is your MELAS, where ME goes for mitochondrial encephalopathy, LA goes for lactic acidosis, and S goes for stroke-like symptoms. Okay, remember this. Now, let's discuss about some important Mendelian patterns of inheritance. हमें ये पता है there are 4 important Mendelian pattern of inheritance. Those are autosomal dominant, autosomal recessive, X-linked dominant, and X-linked recessive. Now let's see what are the differences. Okay, so in cases of autosomal dominant, what happens? The male is to female ratio is equal. That is, equal number of males and equal number of females would be affected, because the mutated allele, okay, the mutated allele is what? It is located on the autosomes. It is not located on the sex chromosomes, because therefore it is not creating any difference. So please remember, the incidence in males and females is equal in cases of autosomal conditions, like autosomal dominant may be or autosomal recessive condition may be. Male and female incidence would be totally equal, right? Now next one, और क्या difference दिखता है हमें usually? In cases of autosomal conditions, autosomal dominant conditions, it is usually manifested in heterozygous condition. It is usually manifested in heterozygous condition. What do we mean by this? So this is your normal genotype, right? This is your normal genotype XX. So if one of the allele is defective, this is known as your heterozygous condition. Only one of the allele would be defective. If both of the alleles are defective, it would be known as a homozygous condition, right? So usually autosomal dominant condition manifests only and only as a heterozygous condition. Okay, heterozygous condition means autosomal dominant usually manifests as a disease, because if autosomal dominant condition would be seen in a homozygous condition, that fetus will die in utero itself. Okay, so please remember, homozygous autosomal dominant pattern of inheritance is incompatible with life. It is incompatible with life. The fetus cannot survive. Okay, please remember this. Therefore, autosomal dominant pattern of inheritance is always heterozygous. Okay, the parents, one of the parents or both of the parents would be heterozygous. Okay, so please remember, one or both of the parents should be heterozygous, right? And therefore only it would lead to affected progeny. In cases of autosomal dominant condition, there would be no skipping of generation. No skipping of generation. Okay, in all the generation, one or the other child would be affected for sure. Okay, 100% guarantee है कि हर एक generation में कोई ना कोई बच्चा affect होगा. Either that child would suffer from the disease or that child would be a carrier of the disease. But कोई ना कोई बच्चा usually will suffer from the disease. Mostly in autosomal dominant conditions, we could not see carriers. Only there are deceased individuals, right? Important one. Okay, and in this condition, the question which is commonly asked, how much percentage of the progeny would be affected? So please remember, 50% of the progeny is affected in cases of autosomal dominant conditions. Now moving on to a next pattern of inheritance, that is autosomal recessive. Okay, in this it is autosomal recessive. Okay, autosomal means once again the affected allele is located on an autosome, not on a sex chromosome. Therefore the incidence in males and females would be equal. Okay, equal number of males and females would be affected, first condition. Second, autosomal recessive condition usually manifests in homozygous condition. Okay, autosomal recessive तभी manifest करेगा clinically when both of the alleles are affected, when both of the alleles are affected or mutated, right? Only and only then the autosomal recessive pattern of inheritance will show disease, right? If there is a heterozygous condition in this, then it was known as a carrier. If there is a heterozygous condition in autosomal recessive, then this person would be known as a carrier, right? So please remember, in cases of autosomal recessive, the parents must be homozygous. The parents must be homozygous. This is more important. Or both the parents should be heterozygous. Then and then only the condition would manifest. okay, in autosomal recessive. Along with that, we can see skipping of generation. मतलब क्या होता है, the disease was present in grandparents, then in parents the disease was completely absent, and then again in the grandchildren the disease is present. Okay, so बीच में एक generation में disease आया नहीं, this is known as your skipping of generation. Okay, so skipping of generation is present in autosomal recessive, it is absent in autosomal dominant. And how much percentage of the progeny is affected? So please remember, 25% of the progeny would be deceased in cases of autosomal recessive condition, and 50% of the 25% of the progeny would be carrier. So याद रखना, 25% are carriers, 25% are deceased, right, in autosomal recessive condition. Moving further to our next one, that is X-linked dominant. So now this is sex linked, right? So as it is sex linked, and as usually females have 2 X chromosomes, so what happens, if one of the allele is also mutated, they have another allele to cover up for this, right? So in every condition, in X-linked dominant conditions, usually, okay, in X-linked conditions the females are mostly carriers. Okay, the females are mostly carriers. I'm not saying 100% of the times, they are mostly carriers. Okay, whereas males are mostly deceased individuals. Okay, this is a basic thing that you need to remember, but then you need to differentiate in X-linked dominant and X-linked recessive. So देखते हैं कैसे differentiate कर सकते हैं, right? So please remember guys, usually what happens in X-linked dominant condition, if a mother is affected, okay, if a father is affected, 100% of the daughters would be deceased. So please remember, in X-linked dominant condition क्या होता है, if a father is affected, 100% of the daughters would be affected, and if a mother is affected, 100% of the sons are affected. Okay, ये उल्टा होता है. If mother is affected, 100% of the, what happens, if father is affected, 100% of the daughters are affected, whereas if the mother is affected, 100% of the sons are affected, right? So this is usually seen in X-linked dominant condition. Whereas in X-linked recessive condition, if mother is affected, she can transmit the disease to all the males in the second generation. She can transmit the disease to all the males in the second generation. Please remember this. This is your X-linked recessive condition. Now, please remember, X-linked recessive condition is much more common in males as compared to the females. ठीक है? So X-linked recessive condition में usually the females are only carriers, whereas the males are deceased individuals. X-linked recessive में males are mostly deceased, whereas females are mostly carriers. Whereas X-linked dominant में क्या दिखता है? If father is affected, he will transmit the disease to all the daughters, right? Now moving further, these are some important examples. Usually examples ही पूछे जाते हैं exam में, and there we have some mnemonics for these patterns of inheritance. Okay, which of the disease follow which pattern of inheritance. So starting with our autosomal dominant pattern of inheritance, okay, which has a mnemonic, he has a very dominant father. Okay, the mnemonic for autosomal dominant is he has a very dominant father. So H goes for hereditary spherocytosis. Hereditary spherocytosis, unchirin proteinase defective, right? It is a type of hemolytic anemia. Hereditary spherocytosis. Second H goes for Huntington's chorea. Huntington's chorea, it is a trinucleotide expansion repeat. Okay, so please remember, it is trinucleotide repeat. इसमें CAG जो trinucleotide होता है, it keeps on repeating again and again and again. Okay, so this is a condition, this is the basic pathology, and it has autosomal dominant pattern of inheritance, Huntington's chorea. Then A goes for adult onset polycystic kidney disease. Then V goes for von Willebrand disease or von Hippel-Lindau syndrome. D goes for dystrophica myotonica. O goes for osteogenesis imperfecta. M goes for Marfan syndrome. I goes for intermittent porphyria. N goes for neurofibromatosis type 1. A goes for achondroplasia. Okay, N goes for neurofibromatosis type 2. T goes for tuberous sclerosis. And last, F goes for familial hypercholesterolemia or FAP. FAP, we mean familial adenomatous polyposis. Okay, which is a predisposing condition to colorectal carcinoma. Right, so this is the mnemonic for your autosomal dominant pattern of inheritance. All these disorders usually inherit by this pattern of inheritance. Now second is your autosomal recessive pattern of inheritance, for which the mnemonic is A, B, C, D, E, F, G, H, I. Okay, by A we remember alpha-1 antitrypsin deficiency. A, alpha-1 antitrypsin deficiency, also ataxia telangiectasia. Ataxia telangiectasia. By B, beta thalassemia or sickle cell anemia. So please remember, by B we remember beta thalassemia, and one more hemoglobinopathy, that is sickle cell anemia. Then next one, C say cystic fibrosis or congenital adrenal hyperplasia. Cystic fibrosis and congenital adrenal hyperplasia. D say deafness. E say emphysema usually, E से emphysema, F से Friedreich's ataxia, F से Friedreich's ataxia, and this question have been asked previously on Friedreich's ataxia. G से Gaucher's disease, G से Gaucher's disease, G से glycogen storage disease और G से galactosemia. So please remember usually एंजाइमोपैथीज जो भी होती है यूजुअली दे इनहेरिट बाय ऑटोसोमल रेसेसिव पैटर्न ऑफ इनहेरिटेंस. कुछ एक्सेप्शंस है विच विल बी डिस्कसिंग. सो प्लीज रिमेंबर मोस्ट ऑफ द एंजाइमोपैथीज इनहेरिट बाय ऑटोसोमल रेसेसिव पैटर्न ऑफ इनहेरिटेंस विद सम एक्सेप्शंस. ओके, next is hemochromatosis, H for hemochromatosis or homocysteinuria, and I for inborn errors of metabolism, I for inborn errors of metabolism. This is your autosomal recessive pattern of inheritance by which all these diseases will inherit. Next one is your X-linked recessive pattern of inheritance, for which the mnemonic is Lady Harding College girls don't care about fake words. Okay, so this is the mnemonic for you. X-linked recessive में क्या होता है? So please remember L goes for Lesch-Nyhan syndrome. Okay, Lesch-Nyhan syndrome due to HGPRT deficiency. Question in your FMG 2021 session. Lesch-Nyhan syndrome. Then H goes for hemophilia type A and type B, and also for Hunter's disease. Hunter's disease is a type of mucopolysaccharidosis. बाकी सब mucopolysaccharidosis they inherit by autosomal recessive pattern of inheritance, except Hunter's disease which inherit by X-linked recessive pattern of inheritance, which is a type 2 mucopolysaccharidosis. Remember this. Okay. Then C goes for color blindness. Question has been asked on color blindness twice. Okay. Then next one is G6PD deficiency, that is glucose 6-phosphate dehydrogenase deficiency, and G6PD deficiency leads to hemolytic anemia, and this is also exception. So please remember most of the enzymopathies inherit by autosomal recessive pattern of inheritance except G6PD deficiency which inherit by X-linked recessive pattern of inheritance. Next one, C goes for chronic granulomatous disease, CGD, that is due to defective NADPH oxidase enzyme. Then A goes for A-gamma globulinemia. F goes for Fragile X syndrome, and for Fabry's disease. Fabry's disease is also an exception, guys. Please remember this. And last, W goes for Wiskott-Aldrich syndrome. Right? Now, last one, last pattern of inheritance is your X-linked dominant pattern of inheritance, for which the mnemonic is Ravi. Okay? So please remember, where R goes for Rett syndrome, A goes for Alport syndrome, V goes for vitamin D resistant rickets, and I goes for incontinenta pigmenti. So please remember, these are some important disorders which inherit by X-linked dominant pattern of inheritance, right? So I feel X-linked recessive and autosomal recessive have always played an important role. Okay, याद रखना क्योंकि वो confusing है थोड़े. Therefore they usually play in these two. And sometimes definitely questions can be asked from autosomal dominant also, like questions have been there on achondroplasia, on neurofibromatosis, on osteogenesis imperfecta, okay, on polycystic kidney disease, on hereditary spherocytosis. Question have been asked on these some of the disorders that I've already mentioned now, right? So with this we end our session for today. Thank you so much. Let's meet you in the next session of Sparks, and till that, goodbye, good luck.